Thanks for that, Ben. I hadn't skied before I went to Calgary to do my fellowship, but I now love it as much as many others do. So I think you're on the money with that guess. I'd just sort of like to echo the sentiments of both Ben and Catherine about all of the behind-the-scenes stuff that goes on to put on a day like this. I've organised this for myself in the past. I know it's a tremendous amount of work, so Ben, you deserve to be congratulated for getting the day together. And obviously, it's not something you do on your own. And yeah, not only am I grateful for the opportunity to speak, I'm really grateful that the opportunity for everyone to attend today exists. And I encourage you to thank the relevant people in the breaks. We were just joking at the table about the surgery talk is always first. The surgery always comes first in the journey for someone with a brain tumour. So I get to go first, and hopefully it's an act that everyone can follow. My kind of overview of my talk, some of the questions in the program that hopefully I'll address is about some general comments about surgery and the role of surgery, when the best time to resect is, talk a little bit about benign versus aggressive lesions, and then what to expect. So surgery for brain problems is not new. It was done in sort of prehistoric times, but there's skulls that have been found with evidence of healing after craniotomies, despite very, very primitive concepts of septic technique and anaesthetic and all those sorts of stuff. Obviously, what we're looking at now is a much more sort of modern way of approaching things, where we have these tumours that can look quite subtly different to the normal brain, how we go about surgery in such a way that's safe and that's in the patient's best interests. So there's a few key concepts for us to understand about surgery, and I try and educate my patients about this in terms of the way that we approach surgery and some of the thinking behind the sorts of operations we do, why we do them, and how we do them. So when tumours arise in the brain, there's really kind of two ways that they turn up. So it's either a very localised thing, something that's a lump, and quite obviously that's something that that if we can remove it, then that's very good because the whole of the tumour is gone. Obviously in the brain we don't have the luxury of elsewhere in the body, and this is something I find myself saying every day, is that in the bowel, if you have a tumour, you can take a foot of the bowel out and put it back together and you're fine, or anywhere else in the body we can use the same sort of analogy, whereas in the brain obviously it's high price real estate. So we have tumours that are diffuse, and yes, there may be a lump, but there's also cells that extend into the surrounding brain, and we can't remove all of the tissue because a lot of the tumour cells are in brain that's functioning normally. So our concept with surgery is then to kind of try and remove what we can. But surgery is always to some degree ineffective because there's always tumour cells beyond what we can see. And this is a great graphic because it sort of shows a lump, and then there's some cells in the area around and cells further away and further away. Okay, and this is why we work so effectively. We have to work effectively as a team, with radiation and with chemotherapy and other treatments to try and control what tumour is left behind. So then if you think about it, then why do we operate at all, right? Like if this isn't something that surgery is going to cure, then could we just rely on other treatments? And again, that's where a lot of the subtleties of different types of lesions and trying to predict based on imaging, and I'll talk about imaging again later on, how tumours are going to behave. So whether they're a low-grade lesion, something that grows slowly, or a high-grade lesion. Obviously the location is a very, very important thing, and that'll be something I'll come back to as well. But ultimately the main reason for surgery in some respects is getting some definitive pathology, finding out exactly what we're dealing with. And as much as we do have this sort of long list, this is from the most recent sort of pathology book that the WHO puts out, we always have some idea what we're dealing with. obviously the subtleties are beyond what we can assess generally with scans, and even with evolution of scanning technology and different sorts of sequences like MR spectroscopy, things like that, we can predict more reliably, but there's always a bit of a guess. Now, a couple of things just to say about this. So first of all, we've got this list of the different astrocytomas and oligodendrogliomas. And then the IDH status is important, that is something that many of you may have come across. But even within these groups, we know that tumours are going to behave differently, and that's because of the nature of these tumours being very, what we call heterogeneous, that different regions of the tumours behave different to other regions. So as time goes on, we're knowing more and more about, less and less to some degree, knowing how variable these tumours are. So obviously, getting pathology and getting tissue to be able to assess it and try and work out what treatments are going to be best, let alone what this is going to mean for the individual in question, becomes more and more important. So why do we operate? Well, like I say, primarily it's tissue sampling, finding out what we're dealing with. The second thing is what we call decreasing mass effect, okay? So that's where we have a lump in the brain, the skull's a box of a fixed size, you put something extra in there, it causes pressure, it causes problems. By reducing the mass effect, we can, reduce headaches, things like that, okay? And that's how we can reduce symptoms. So often, it's not actually the tumour itself is invaded and is disturbing, for example, motor pathways, visual pathways, speech pathways. It's the pressure that it's causing that's causing the symptoms. There's also this principle about decreasing the cell number, or what we call cytoreduction. So if you think that there's less cells that the chemo or the radiation has to work on, then perhaps it's going to work better. And this is a very controversial kind of topic, and something that there's a lot of discussion about. And obviously the correlate of that is then, if reducing the mass effect and reducing the number of cells that the other treatments have to work on, does that mean that the bigger a resection we do, that's going to be better for the patient? But again, it really all comes down to location, and this graphic just shows a number of tumours all in different parts of the brain, some of which are in very dangerous spots, some of which are extensive. Some of them form more of a lump that might be able to be removed, okay? So when we're talking about, that then comes down to this big question that as surgeons we're always reflecting upon is, does resection help with survival in glioma? This is a bit of an old slide, but this is a table of studies, that some of which favour a more extensive resection and some of which do not favour any resection group. These studies are ongoing. So, when we look at that graphically, there probably is a modest improvement in survival if we're able to remove all of the tumour. Now, I choose those words very carefully because it's often not a question of whether or not the surgeon's done a good job. Of course, I'm going to defend my kind, but it's also a question of the nature of the tumour, where it is, which part of the brain it's in, and whether that lends itself to being resected. So, what that always then comes down to is where the tumour is located. It becomes a compromise of the extent of resection versus leaving a patient with a neurological problem, okay? And this is something that's very, again, this is really, I think, the art of glioma surgery, is working out how much we can do without leaving anyone in a worse condition. Now, and that's because we know that one of the most important predictors of patients' outcome is their so-called performance score, or sort of what level of help they need, how mobile they are, and how they can get around. But obviously it just has a huge impact on quality of life, okay, if you have a deficit. Having said that, there are some tumours that are curable with surgery, so, and we need to predict that ahead of time. So this is an example of a patient I operated on 2 weeks ago. He has this tumour here in this, or had this tumour here in this deep location that looks very dangerous, and it is. The motor pathways on another scan I could see were pushed just to the back of it. Obviously this is high risk surgery. He'd had a previous biopsy, and this was a pilocytic astrocytoma, and that's a tumour that is basically curable with surgery. So this is someone that, rather than saying, I'll do a biopsy and I'll have a and I'll make sure that he's in good nick, and then over to Michael and how, when, or all the equivalents thereof. This was someone that I knew if I could do a good operation on him and remove all of the tumour, then, you know, he's likely to do very well, and thankfully he was intact after the surgery. And this goes, you know, we tend to focus this day on glioma, but this goes even further into other tumours, meningiomas, for example. This is a good example of a meningioma that's quite a large tumour at the base of the brain here. And knowing if I remove this, that that's curative, then obviously that's going to affect my decision making going forward. But of course it comes back to that concept, this key concept of the lumps versus the diffuse problems, okay? So then if we think about, if we have diffuse tumours, what are the kind of factors that we need to think about, okay? So the accessibility of the tumour, the size of the tumour, and, you know, again, thinking about how long surgery might take, and we'll talk about that in a weight craniotomy. We think about areas that we call eloquent brain, so things that are like speech area, motor, sensory, and other speech areas, and then the visual areas. There's quite clear definitions of where the tumour is. You know, what sort of mass effect it's causing, and then obviously the diagnosis. And again, even within that long list of pathologies, we know that some of the tumours are more likely to be sensitive to radiation, more sensitive to chemotherapy. Again, part of the art is, do I subtotally resect something with knowing that it's going to respond, again, to Michael, to how, when. But obviously my main thing is surgery and safety of surgery, okay? So, you know, I obviously don't want to cause problems in the process of trying to improve things. And what are some of the things that we have at our disposal now to make surgery safer? Imaging is kind of the key thing. It's such a mainstay of neuro-oncology, and there's all sorts of different scans that have come on board. So the most common scan we see is the so-called gadolinium enhanced T1 weighted imaging, which are those scans I've showed you where we see the white balls basically, right? These tumours take up the contrast against the background of a T1 weighted brain image. MR spectroscopy, we talked about that a little bit. I mentioned that before. There are all sorts of patterns of uptake on, on the spectroscopy that are interesting and can help us not so much tell by and large between different types of tumours, but they can help us tell if things are tumours versus infection or versus demyelination, like MS, things like that. There is one particular type of MR spectroscopy which I've neglected to put in this slide, called 2HG spectroscopy, which is something for the IDH mutation, which I mentioned earlier. That's something that's having an increasing role. And I suspect over the next 5, 10, 20 years, we're going to see more and more of these so-called metabolites, the things that MR spectroscopy detects for, becoming important in tumour diagnosis. Functional MRI is a key thing, so where we have, and particularly with tumours where, as much as I can look, and you saw that graphic of the eloquent locations in the brain, and I can look and based on you know, anatomical knowledge, predict that these are areas that are important. Everyone is a little bit different, and sometimes tumours are pushing those areas away, and we don't know if we're pushing them forward or back or up or down. So an MRI where you're tapping your finger or generating verbs in your brain and those sorts of things can be helpful, and I'll show you a couple of examples. Diffusion tractography is a technique that we're starting to do some more work with at North Shore, where it looks at the tracts of the brain, so the visual tracts, the motor tracts, looks where they might be relative to the tumour, and again helps me think about how I might go about the surgery. And then intraoperative MRI, that has a role too, more really for extent of resection. And again, so for an intraoperative MRI to be useful, you have to kind of, I guess, buy into the sort of complete gross total resection kind of argument, which again is very controversial and I won't dwell on, but it's another thing that's out there that people talk about. The biggest advance, however, is what's called frameless stereotaxy, okay, which again, some of you will have had MRIs with these dots on your head that get then loaded up onto the computer, and using this little probe and this infrared camera, it tells us basically where we are on the skull or in the brain relative to the scan, because obviously, again, like somewhere else in the body, we can't feel where a lump is that we need to cut out. And so that can help us plan where we're going to make the craniotomy. We have this probe, have this camera, and the image is displayed on the screen, and that helps us know where to go. So that's a massive advance for us because of being able to find tumours and have some idea where the boundaries of tumours are. Neuroanesthesia has been, the advances in that have been quite massive over the years. So in terms of using really short-acting, TIVA stands for total intravenous anaesthetic, so drugs like propofol and remifentanil that act really quickly. That helps us with the surgery. It helps us, again, in situations where we're doing things awake, keeping people out of pain and letting them wake up quickly if needed. But also that early post-operative period, it decreases complications because these things are not very long acting, so people are wide awake fairly shortly afterwards, and if they're not wide awake, it might mean it's a problem. Obviously, the different anticonvulsants that we use, it's been dilantin for a long time, but Keppra on board the last sort of 10 or so years, and that the safety of Keppra has been a huge advance because it, particularly around the perioperative period and decreasing seizures, and then, awake craniotomy and the techniques that have gone along with that. When do we do awake craniotomies? Well, it's really about patient factors, so there's a little bit of picking the person who we think will be able to tolerate it, but it's mostly about tumour factors, which part of the brain, if it's near one of those eloquent locations, and then the pathology. We tend not to do as much awake surgery for higher grade problems because higher grade tumours look very different to normal brain, whereas even that example I showed at the start of the talk, it's very subtle, the difference between the tumour and the normal brain. So here's a couple of examples. This is the functional MRI, which shows where the motor cortex is relative to this, what was actually a brain metastasis. So that would be something we'd do asleep because we know that it's very, and again, brain mets also look very different to the normal brain usually. This patient had this lesion in his left frontal lobe, right-handed patient, speech is on the left side. But I thought it was a bit away from his speech area, and it was. So this patient had a resection under general anaesthetic, and it was an anaplastic astrocytoma. This patient, however, a bit different. This is also in the frontal lobe, but it also goes down to the part of the brain called the insular cortex. He had a functional MRI. This is now a coronal image, so it's just above where the tumour is. So I was able to remove a lot of the tumour away from where the speech area is first, moving towards the speech area and then stopping when he started to have some speech problems. I left that component in the insular cortex, and that was also an anaplastic astrocytoma. And you can see this is where the hole was, and this is after radiation, where even all this sort of darkness here that was the tumours really shrunk away with radiation. We still get faced with these sort of problems where it's a deep tumour going across the corpus callosum, it's on both sides, it makes it very difficult to resect. We can either remove part of the tumour, and we try to where we can because that reduces mass effect, but sometimes that we worry about doing that because of the risk of bleeding from the tumour that's left. So there's still a role for stereotactic biopsy. This is an example with a patient in a frame. Sometimes we do it frameless as well. But these are the situation where we, for want of a better way of saying it, kind of cut our losses and say, well, we can't remove a huge amount of this tumour. Let's keep the patient in good clinical condition and then over to the rest of the team and for the treatment. So to summarise what we think about surgery, it's the primary aim is to obtain a diagnosis, okay? Obviously, we want to treat mass effect and remove the bulk where we can. And the location of the tumour is a critical factor, obviously, as well as what we think the pathology is going to be based on those advanced imaging techniques, based on patient factors as well, age, gender, tumour location. And there's always a number of options for surgery. And the other question, I guess, is will I have surgery again? Obviously we talked about the order. It tends to be that, I do an operation and Michael and Hal Wen do their treatments. I often come back into the picture. there's a number of variables in terms of the pathology, in terms of other treatments. So sometimes other treatments can cause what we call treatment effect, or there can be contraindications to further surgery with some treatments like Avastin. And then, basically patient factors such as the clinical, condition of the patient, and other tumour factors. So what do I see my role, and what's the role of the neurosurgeon? We're kind of at the start of the process. It's obviously a very dramatic time. It's a scary time for patients and their families. And, it's a real privilege to be able to be part of that and to offer the support I can. Obviously, we're the ones making the diagnosis based on the radiology and histopathology, and then, follow up basically for re-resection. And as far as we've gone, things continue to evolve, and, I look forward to seeing the advances that we make with surgery over the next few years. Thank you very much, and I think we're holding questions till the panel. Is that the plan? Okay, thank you.